Hello students. Welcome to chapter 67 part 2, and let's start with prostate cancer. Let's start with the video, okay? Okay, prostate cancer animation. Here we go.
Considerations in advanced prostate cancer. Prostate cancer is the most commonly diagnosed cancer among men in the United States, excluding certain skin cancers. A common misperception about prostate cancer is that it is rarely fatal. In fact, it is the second leading cause of cancer-related death among men in the United States. While it is true that prostate cancer is largely curable when diagnosed and treated early, patients with advanced prostate cancer have a less favorable prognosis. Advanced prostate cancer is defined as cancer that has spread beyond the original tumor. The most recent statistics estimate that 3 out of 10 men are still alive 5 years after being diagnosed with advanced prostate cancer. Male hormones, such as testosterone, cause prostate cancer to grow and survive. Early treatments for prostate cancer attempt to lower levels of testosterone in the body. This is known as hormone therapy. However, prostate cancer tumors may eventually begin to grow again, even though levels of testosterone in the body are low. At this point, the cancer is considered to be advanced. Researchers are studying why this occurs to gain a better understanding of how to develop treatments for prostate cancer. Talk to your doctor about questions you may have about advanced prostate cancer. Recent basic science and medical evidence suggest that one possible reason that tumors continue to grow is that they become extremely sensitive to the low levels of testosterone that surround them. In this way, tumors can grow even though there are extremely low levels of testosterone in the bloodstream. Additionally, studies done in both animals and humans show that the tumor may begin to produce its own supply of testosterone. This means the tumor is capable of fueling its own growth. In other words, in advanced prostate cancer, there is evidence to suggest that the tumor may be providing its own testosterone so that it can grow without depending on other sources of testosterone production. Talk to your doctor about new information regarding advanced prostate cancer.
Wow. Okay. So, testosterone and dihydrotestosterone, DHT, which I told you is the potent form of testosterone, are the major androgenous male hormones in the adult male. Testosterone is produced by the testes and circulates in the blood. DHT is a testosterone derivative in the prostate gland. In some patients, the prostate grows very rapidly, leading to non-cancerous high-grade prostatic intraepithelial neoplasia. This impairment of cellular regulation causes men to be at a higher risk for developing prostate cancer than men who don't have that growth pattern. Many prostate tumors are androgen sensitive. Most are adenocarcinomas and arise from epithelial cells located in the posterior lobe or outer portion of the gland. Of all malignancy, prostate cancer is one of the slowest growing, and it's metastasized in a predictable pattern. Common sites of metastasis are the nearby lymph nodes and bones, although it can also metastasize to the lungs or liver. The bones of the pelvic, sacrum, and lumbar spine are most often affected. Describe staging categories of localized and advanced cancer are detailed in chapter 19. So, etiology and genetic risk. Advanced age is the leading risk factor for developing prostate cancer. The risk increases for men who have a first-degree relative, father or brother or son, with the disease, and if they are from African American descent. So you have here the prostate gland with cancer and benign prostate hyperplasia. You can see the BPH is usually inside, right? Close to the urethra, the tube that let the urine pass, while the cancer is most in the outside, right? Okay. Prostate cancer affects African Americans more often than other ethnic racial groups. African American descent who live in the Caribbean have the highest mortality rate in the world. Here comes the that's good to know. Studies are ongoing regarding what role, if any, diet has in the risk for developing prostate cancer or the progression once it has been diagnosed. The hypothesis for that current men's eating and living study is that consuming more fruits and vegetables versus animal fat will slow the progression of aggressive prostate cancer. So, eating more fruits and vegetables versus animal fat, and we have been talking about this the whole semester through the whole chapters and especially in gastrointestinal. There's nothing more healthier than eating fruits and vegetables, especially if they are raw, versus animal fat, right? Especially we need to avoid the red meat. So, it's under study. Many gene mutations play a role in various types of prostate cancer. Some men with the most aggressive prostate cancers have BRCA2 mutations, similar to those women who have BRCA2 associated breast and ovarian cancers. The most common genetic factor that increases the risk of prostate cancer is a mutation in the glutathione 5 transferase, which is a GSTP1 gene. This gene is normally part of the pathway that helps to protect against carcinogen damage. Incidence and prevalence, prostate cancer, I'm going to start call it prostate cancer as PC, okay? PC is the most commonly diagnosed non-skin cancer in men and in the United States. If found and treated early, has a nearly 100% cure rate. If found and treated early. Men older than 65 have the greatest risk for the disease. Again, is a disease that appears in all the people. There are more risks the more age you have. Health promotion and maintenance. Teach men about the most current evidence-based guidelines for PC screening and early detection. The current recommendations from the U.S. Preventive Task Force, again, my recommendation to download the app, U.S. Preventive Services Task Force, are that men age 55 to 69 should make an informed decision about whether to have prostate cancer screening. Okay. Here, other organizations such as the American Urological Association, the American College of Physicians, and the American Cancer Society have varying guidelines. It is important to know for them, men at a higher risk for prostate cancer, including African Americans or men who have a first degree relative with prostate cancer before the age of 65, and you should talk to the provider at the age of 45 about possible screening. So for them, the screening starts at 45. And here comes another good to know. Although a family history of PC cannot be changed, certain nutritional habits can be modified to possibly decrease the risk for the disease. First, teach men to eat a healthy, balanced diet, including decreased animal fat, we know that, red meat, and the intake of dairy products, milk, cheeses, yogurt, okay? Also reinforce the need to increase fruits and vegetables, especially tomatoes, which are high in lycopene. Soy contains phytoestrogens that are thought to be helpful in reducing the risk for prostate cancer. When we are talking about tomatoes, we are not talking about the tomato paste or other type of tomatoes that are coming in cans. You are looking for organic tomatoes, and if you don't have organic tomatoes available, then you put water to boil. When the water is boiling, you submerge the tomato for 2 to 3 seconds, and then you remove it, and then you are gonna be able to peel the tomato. okay? Because the skin is having the most pesticides. So you eat that tomato that way if you cannot find organic tomato, or the patient doesn't have the budget to buy organic tomatoes, okay? Assessment. Recognizing the cues, as for his nutritional habits, especially focusing on the intake of red meat and dairy products as a source of concern, recognize that in early prostate cancer, these are often no signs and symptoms experienced by the patient. So the disease is going and there is no symptoms. You need to assess for urinary elimination if he's taking any medication that could affect voiding, any bladder outlet obstructions, such as difficulty in starting urination, frequently bladder infections, and urinary retention. Ask about urinary frequency, hematuria, we know blood in urine, and nocturia. Ask if he has any pain during intercourse, especially when ejaculating. Pain, particularly bone pain in the hips, the legs, are associated symptom with advanced prostate cancer. Ask the patient if he has had any recent unexpected weight loss. También also you need to ask for changes in sexuality, including libido or function. Ask about current or previous sexual transmitted infection, penile discharge, or scrotal pain or swelling. Most early cancers are diagnosed while the patient is having a routine physical examination or is being treated for benign prostatic hyperplasia. Gross blood in the urine hematuria is a common sign of late prostate cancer. So you don't need to get to that point. Go to your PC screening, and is the recommendation that we have to follow in order to prevent the disease. Pain in the pelvis, hips, spines, and ribs, and swollen nodes indicate advanced disease that has spread, so there is metastasis there. Laboratory assessment, PSA antigen, we talk about this, is a glycoprotein produced by the prostate. If the patient and healthcare provider have agreed to screening, PSA analysis can be used as a screening test for prostate cancer because other prostate problems also increase the PSA level. It is not specifically diagnostic for cancer. Remember that. Here comes the that's good to know. If the test is performed, the specimen should be drawn before the digital rectal examination. This is an NCLEX question, definitely. Okay, it's a tricky question, it's a tricky factor, and you need to know this. If the test is performed, the specimen should be drawn before the digital rectal examination. They are talking about the PSA. If that is taken, it should be drawn before DRE, because examination can cause an increase in PSA as a result of prostate irritation. Normal blood level of PSC in men younger than 50 is less than 2.5. PSA levels increase to as high as 6.5 when men reach their 70s. Is age related. African American men between the ages of 50 and 59 have a slighter higher normal value than men who are Caucasian or Asian. But the reason for this difference is not known. However, levels greater than 4 have been noted in more than 80% of men with prostate cancer. So you have to consider the age, you have to consider the ethnicity, and basically do not tell the patient this is abnormal, because they are genetic, age, and ethnicity considerations. So you don't want to put the patient in the anxiety state. An elevated PCA level should decrease a few days after a prostatectomy for cancer. Okay, an increase in the PSA level several weeks after surgery may indicate that the disease has recurred and is just happening several weeks after the surgery, an increase in PSA. Because PSA is not absolutely specific to prostate cancer, another blood test, early prostate cancer antigen, may be serum marker for prostate cancer. It can reveal changes in the prostate gland early and is very sensitive test. Oh, that's good. Other diagnostic assessment, you have the digital rectal examination and PSA. Most patients have a transrectal ultrasound, which is called TRUS of the prostate, right? Transrectal ultrasound. We don't need to put a video for that, it's obvious. So prostate cancer staging. You're welcome to read all these. Stage 0 goes from a stage 0 to a stage 4. Tumor has spread to tissues near prostate and beyond seminal vesicles such as bladder or pelvis wall. So that means stage 4 is with metastasis. Nursing safety priority, action alert. After a transrectal ultrasound with biopsy, instruct the patient about possible complications, although rare, including hematuria with clots, signs of infection, and perineal pain. Teach the patient to report fever, chills, bladder, urine, and difficulty voiding. Advise him to avoid strenuous physical activity and to drink plenty of fluid, especially in the first 24 hours after the procedure, to have clear urine. Teach him that a small amount of bleeding, turning the urine pink, is expected during this time. However, bright red bleeding should be reported to the healthcare provider immediately. And of course, we have to think about our diabetic patients. We need to have a nice A1C in order for that to heal. And also your patients that are having problems with cardiovascular problems and they're having restrictions with fluid. So especially because they need to drink plenty of fluid. So you need to consider those factors. After PC is diagnosed, prostate cancer, I said I'm going to call it PC, the patient has additional imaging and blood studies to determine the extent of the disease. Common tests include lymph node biopsy, CT of the pelvis and abdomen, and MRI to assess the status of the pelvic and para-aortic lymph nodes. And again, the para-aortic lymph nodes are the lymph nodes that are next to the aorta, and we know that aorta, once it's leaving the heart, goes into the middle of the abdomen and runs from there all the way to the pelvic area and bifurcates right and left. Okay, a radionuclide bone scan may be performed to detect metastatic bone disease. An enlarged liver or abnormal liver function study results indicate possible liver metastasis. Patients with advanced BC often have elevated levels of serum acid phosphatase. Most men with bone metastasis have elevated serum alkaline phosphatase level and severe pain. And we spoke about those markers that are present in most cancers. Preventing metastasis, active surveillance, because PC is slow growing with late metastasis. Again, it's slow growing with late metastasis. That's why it's important to do the PC screening. Older men who are symptomatic and have other illnesses may choose observation without immediate active treatment, especially if the cancer is at an early stage. This option is known as active surveillance. The average time from diagnosis to start of treatment is up to 10 years. So for 10 years, they think that probably the PC is not there anymore. But remember, it's a slow growing. That's why they prefer to watch and see what's going on instead of putting themselves under treatment. During the AS period, the active surveillance period, men are monitored at regular intervals through digital rectal examination and PSA testing. Okay, so besides the active surveillance, under that umbrella, the digital rectal examination and PSA testing is going to be performed. If obstruction occurs and transurethral resection of the prostate, TURP may be done. Non-surgical management may be an adjunct to surgery or alternative intervention if the cancer is widespread or the patient condition or age prevents surgery. Available modalities include radiation, hormone therapy, and chemotherapy. We know that radiation, external beam radiation, comes from a source outside of the body. Patients are usually treated 5 days a week for a minimum of several weeks. I know people, they went even through 28 radiation, right? It's like five um, 5 or 6 weeks treatment. External beam radiation can also be used to relieve pain from bone metastasis. Three-dimensional conformal radiation therapy can more accurately target prostate tissue and reduce damage to nearby organs and tissue. An advanced type of CRT, which is the conformal radiation therapy, is intensity modulated radiation therapy, which provide high dose to the prostate. External beam radiation causes erectile dysfunction in many men well after the treatment is completed. Remind the patient that other complications from this type of radiation, external radiation, include urinary frequency, diarrhea, and acute radiation cystitis, which is the inflammation of the bladder. So that type of radiation, external beam radiation, can cause urinary frequency, diarrhea, and acute radiation cystitis, which causes persistent pain and hematuria in addition. Symptoms are usually mild to moderate and subside 6 weeks after treatment. Okay, so you have here the graphic, the patient position and vital component of prostate brachytherapy and transrectal ultrasound. This is a brachytherapy, okay? They are inserting, right, a seat for 15 to 20 minutes. Radiation proctitis, which is the inflammation of the prostate, may also develop, but is less likely with CRT. We're talking about the side effects of the previous radiation, which is external. Radiation that has irritated the rectum can cause urgency and cramping, which leads to rectal leakage. Like cystitis, this problem usually resolves 4 to 6 weeks after the treatment stops. So all these side effects from the external beam radiation therapy. Low dose brachytherapy involves transrectal ultrasound, CT scans, or MRI, which are used to guide implantation of the seeds, like we can see here in the picture. So are using the rectum to guide, right, where they are going to implant the seeds. These procedures are usually done on an ambulatory care basis under spinal or general anesthesia and are the most cost-effective treatment for early-stage prostate cancer, the brachytherapy. Teach the patient that erectile dysfunction, urinary incontinence, and rectal problems do occur in a small percentage of cases. Fatigue is also common and may last for several months after the treatment stop. Drug therapy may consist of either hormone therapy, androgen deprivation therapy, or chemotherapy. Because most prostate tumors are hormone dependent, patients with extensive tumors, and those with metastatic disease may be managed by androgen deprivation, okay, which is your dihydrotestosterone or testosterone. Luteinizing hormone releasing hormones, agonists, or antiandrogens can be used. So this luteinizing hormone releasing hormone agonists available in the United States include leuprolide, goserelin, estrelin, triptorelin. These drugs first stimulate the pituitary gland to release luteinizing hormone. After about 3 weeks, the pituitary gland is depleted of LH, luteinizing hormone, which reduces testosterone production by the testes. Okay, leuprolide is used most commonly for advanced prostate cancer with the goal of palliation. And here comes another that's good to know. Teach patient taking the luteinizing hormone releasing hormone agonist that side effects include hot flashes, which usually decrease as treatment progresses. The subsequent reduction in testosterone may contribute to erectile dysfunction. So you have hot flashes, erectile dysfunction, decreased libido. Some men also develop gynecomastia. Um, these drugs can also increase the patient risk for osteoporosis and fractures. So the luteinizing hormone release hormone agonists, those drugs causes hot flashes, causes erectile dysfunction, decreased libido, gynecomastia, right? Can cause risk for osteoporosis and fractures. Okay, teach the patient to take calcium and vitamin D and to engage in regular weight bearing exercise. Biphosphonate can be prescribed to prevent bone fractures. And what is our popular biphosphonate we study in this semester? Alendronate. Okay, alendronate. That also has separate side effects, and you should know that, right? Okay, so it's simple. Try to avoid all these side effects, all these treatments and conditions. Get your healthy vegetables, fruit, avoid consumption of red meat, try to lose weight, right? Exercise more. Anti-androgen drugs, also known as androgen deprivation therapy, work differently in that they block the body ability to use the available androgen. So before the luteinizing hormonal releasing hormones agonists, what they are doing is they are stopping the production of testosterone by stopping the command in the pituitary. These androgen drugs, right, work differently because they block the body ability to use the available androgens. These drugs are the major treatments for metastatic disease, includes flutamide, biculamide, nilutamide. So they don't stop the pituitary to release and to produce more testosterone, to give the order, right, to produce testosterone. But what they are doing is that these drugs are giving the order to stop absorbing whatever is there, the testosterone or the hydrotestosterone, DHT, that is available. They inhibit tumor progression by blocking the uptake of testicular and adrenal androgens at the prostate tumor site, of course. So the tumor that needs to be fed with these testicular and adrenal androgens, right, is inhibit to do so by taking this medication. These medications increase the risk for liver toxicity. So that's another side effect, liver toxicity. These medications causes liver toxicity. The other, the list is long. Surgical management, minimally invasive surgery, or less commonly an upper surgical technique for radical prostatectomy, can be performed, which is prostatectomy means that they are going to remove the prostate completely. A bilateral orchiectomy is the removal of both testicles. It's another palliative surgery that slows the spread of cancer by removing the main source of testosterone, the testicles, right? So in men, we have the main source of testosterone are the testicles. In women, the main source of estrogens are the ovaries. Preoperative care. Minimally invasive surgery is more appropriate for localized prostate cancer and is used as a curative intervention. The most common procedure is the laparoscopic radical prostatectomy, often done with robotic assistance. Other procedures include transrectal high-intensity focused ultrasound and cryotherapy, which is they are freezing the cancer cells. Patients who qualify for LRP, which is the laparoscopic radical prostatectomy, must have a PSA less than 10 and have had no previous hormone therapy or abdominal surgeries. Remind the patient that the advantage of this procedure over open surgery includes decreased hospital stays, of course. In an open surgery, you need to stay at least a week, minimal bleeding, a smaller incision and scarring, decreased time for urinary catheter placement, usually removed on third postoperative day, and that is one of the causes of hospital infection, the catheter, okay, in the hospital. So you don't want to be catheterized in the hospital. There is a high risk of infection. Nerve sparing advantage, okay, that's a good benefit. Okay, for the patient undergoing an open radical prostatectomy, provide preoperative care as for any patient having surgery. So infection, we need to check for pain, blah, blah, blah. Operative problems, procedures. For the laparoscopic RP procedure, the patient is placed in lithotomy position with a step trendelenburg. We know that. A laparoscope, because the trendelenburg is going to put all the bowels, all the intestinal cavity is going to be is not going to cause pressure on the tissue that is going to be having the procedure. A laparoscope with a camera on the end is inserted through one of the incisions while other instruments are inserted into the other incisions. The prostate is removed along with nearby lymph nodes, but perineal nerves are not affected. The open radical prostatectomy can be performed via several surgical approaches depending on the patient's desire and outcomes of the staging of the diseases, right? The surgeon removed the entire prostate gland along with the prostatic capsule, the cuff at the bladder neck, the seminal vesicles, and all the other pieces that are important to be removed. Postoperative care, there is a box with nursing interventions that you need to pay attention, maintaining hydration, caring for wound drains, managing pain and preventing pulmonary complication, right? Assess the patient level patient's pain level during the first 24 hours after surgery. Administer a stool softener if needed to prevent possible constipation, because the patient is going to have a lot of analgesia. The patient has an indwelling urinary catheter to straight drainage to promote urine elimination. Monitor intake and output every shift, and record or delegate this activity to your assisted personnel, your certified nurse assistant. So here is the box with care after an open radical prostatectomy. Maintain the sequential compression device until the patient begins to ovulate, important to prevent thrombus. Monitor the patient for venous thromboembolism, as I said, and pulmonary embolism. Keep an accurate record and intake and output during drainage from a Jackson Pratt or ordered drainage device. And they were asking me the other day, what is the Jackson Pratt? So you need to be familiarized with that, because in the surgical unit, you are gonna come across this. So let's watch a short video.
Okay. Hi, this is Dr. Whitehead. I wanted to show you how to manage your Jackson Pratt drain. If you have a JP drain, it looks something like this. What you want to do is let the fluid collect like this throughout the day. When it's on suction and a side is dented in, that's how it's supposed to be. Once a day, you're going to take the tubing, hold it at the body so you don't pull it out, and basically just squeeze and pull, squeeze and pull, squeeze and pull, all the way till you get to the end to make sure that there's no clot in there. When it gets full, or every 24 hours, you're simply going to pop the top like this, take a picture of the drain exactly like this so I can see what's in it and how it's settling out. Discard the fluid. squeeze the drain completely again, recap to put on suction, and you're good.
Thank you, doctor.
Okay.
So you have to make sure that you're going to squeeze before capping the Jackson Prats. Okay, that's one thing. The other thing is that you need to document how much fluid. The doctor is telling you to report every 24 hours to empty the Jackson Prats. But if you see that the device is full before that, that's something you need to know because there's a lot of bleeding, right? So that's, and you have to observe for the nature of the blood, if it's just watery, you know, pinkish or bright red. All these things you need to observe. Teach the patient how to care for urinary catheter because he may be discharged with the catheter in place, and emphasize the importance of not straining during a bowel movement, yet to avoid suppositories or edemas. And that's good to know. Okay, not straining during a bowel movement, yet to avoid suppositories or enemas. You know, patients, when they are desperate, they want to have a bowel movement, they will do everything. Ambulation should begin no later than the day after surgery because we need to prevent thromboembolism. Okay, provide assistance in walking the patient when he first gets out of bed. Assess for scrotal or perineal swelling from the disrupted pelvic lymph flow. If this occurs, elevate the scrotum and penis and apply ice to the area intermittently for the first 24 to 48 hours. Okay. Many patients who have the minimally invasive technique are discharged 1 to 2 days after the surgery and can resume usual activities about 1 week or two. Remind patients that common potential long-term complications of open radical prostatectomy are erectile dysfunction, we know that, and urinary incontinence. For ED, drugs such as sildenafil may be effective. This is your Viagra, which lasts 4 hours. Urge incontinence may occur because the internal and external sphincters of the bladder lie close to the prostate gland and are often damaged during the surgery. Kegel perineal exercise may reduce severity for urinary incontinence after radical prostatectomy. Teach the patient to contract and relax the perineal and gluteal muscles in several ways. So these are the steps and how to do your Kegel exercises. Show him how to inhale through pursed lips while tightening the perineal muscles, and how to exhale while when he relaxes. Coordination and transition management. Interprofessional collaborative care is the man with prostate cancer should include his partner if he agrees. Recognize that the patient and partner have specific physical and psychosocial needs that should be addressed before hospital discharge and managed. Should continue in the community setting. As I said before, you have to assess for all these support groups before the surgery and the treatment to see if he is going to be able to continue to be compliant with the treatment, drugs, therapy, nursing recommendations, and everything else. Home care management collaborate with the case manager to coordinate the efforts of various healthcare providers, surgical unit, nursing staff, and as specified in the Joint Commission and other accredited agency, continuity of care is essential when caring for a patient because he may need weeks of months or months of therapy. Another that's good to know paragraph, an important area of teaching for the patient going home is urinary catheter care. An indwelling urinary catheter may be in place for 3 days for the patient who had laparoscopy procedure, or up to several weeks for the patient who underwent an open radical prostatectomy. Teach him and his partner how to care for the catheter, use a leg bag, and identify signs and symptoms of infection and other complications. So urinary catheter care at home, here is the full box with all the recommendations. This is the most important part. besides the procedure, this is the part you want to prevent infection. Okay. Encourage the patient to walk short distances. Lifting may be restricted. Remind him to maintain an upright position and not to walk bent or flexed. Vigorous exercise such as running or jumping should be avoided for at least 6 weeks and then gradually introduced. By contrast, patients having the minimally invasive laparoscopic surgery can usually return to work and resume activities. And that's good to know. Teach the patient not to strain to defecate, and we spoke about this a few paragraphs before. A stool softener may be prescribed to reduce the need for straining. If an opioid is prescribed for pain management, you know what's going to happen. There is a high risk for constipation. So you need to get a stool softener prescription and tell the patient not to strain when having a bowel movement. If the patient had an open radical prostatectomy, teach him to adhere to the surgery recommendation. When he can first shower and to continue showering for the first 2 to 3 weeks rather than soak in a bathtub. Okay, it's better to shower always. Always is better to shower. You reduce the amount of bacteria that could be getting into your private parts. Let's call it this way. So, healthcare resources, the American Cancer Society, the Man-to-Man program, the Prostate Cancer Education and Support Network, National Alliance of State Prostate Cancer Coalitions, and some have erectile dysfunction, some patients for the first 3 to 18 months after prostatectomy. Refer them to a specialist who can help with this problem. ED is discussed in another chapter. Refer patients with urinary incontinence to a urology who specializes in this area. Discusses also incontinence management in detail in chapter 61, as I see here. Okay, we have finished part 2 of chapter 67. When we come back, we're going to check for, we're going to analyze testicular cancer.